My name is Dr. Perper. I'm from New York. My topic today, contrast spread technique, algorithm, and study. Seeing is believing, but feeling is the truth. This is the quote from 17th century by English clergyman. I was supposed to give this talk in Dubai this spring, but because of COVID, it was canceled. Interestingly, that the architecture, ancient architecture of Emirates is similar to ancient architecture of Uzbekistan. Emirates, Uzbekistan. I visited Bukhara last October, and this is the place we stayed. And this is a nun from a local market. I'm presenting my own ideas and the technique that currently are not supported by any major organization. One day, at the end of July of 2014, I was performing cervical epidural steroid injection when I recognized I'm doing something different. Instead of relying on loss of resistance for epidural space identification, I was injecting contrast and I was following its spread. I simply was looking on the monitor, analyzing where does it go, away from epidural space or inside it. I call this technique contrast spread technique and wrote an article. I keep exploring this technique when two paradoxical findings appeared. First, there is no need for loss of resistance syringe. And second, there is no need for special epidural needles. Precise placement is paramount for this technique. And a regular spinal needle works well for that purpose. I wrote another article. Over the years, me and my colleagues performed more than 1,600 of cervical epidurals with this technique. We summarized our experience in algorithm that we first presented at SIS convention held in New York City in August of 2019. SIS is Spine Intervention Society. Before I'm going to talk on algorithm, I want to explain technique. So I divided the whole process in two steps: needle insertion and epidural space identification. I prefer to place my needle paramedially, simply because it's easier to navigate it this way. However, a traditional midline placement is also acceptable with this technique. Needle advancement performed under contralateral oblique fluoroscopy. And needle placed all the way till it's close to this line over here. We call this line ventral intralaminar line. With proper visualization, epidural space is readily accessible right after it. Then the needle is placed for anterior-posterior view, fluoroscopy, for confirmation of ipsilateral needle location. I'll explain why is it important later. Epidural space identification is performed with injection of a small amount of contrast, no more than 0.1 or 0.2 cc. And here you may see the spread away from epidural space. For the needle advancement resulting in spread beyond ventral interlaminar line inside the epidural space, I call this moment breaking point. It's when the spread away becomes spread inside. It is similar to loss of resistance when practitioner goes, and bingo, this is it, gets loss of resistance. Then once you have the contrast injected for confirmation of proper epidural spread and two images, oblique and AP, are saved for the records. Here you may see patch epidural spread and nerve roots outlined. I also described this technique in video that was published on YouTube. Please watch it. So we created the algorithm where we explore different scenarios with contrast spread technique when needle is located before, at, or beyond ventral trilaminar line. If the needle is before ventral trilaminar line, advance it. And in majority of cases, further needle advancement will follow with the epidural spread, and then you inject. However, it could be occasions when needle looks deep, beyond ventral trilaminar line, but there is no confirmatory epidural spread. And usually it happens for two reasons. It's either improper visualization of the needle or loss of laterality. I will explain. I call it mirror effect. Objects in mirror are closer than they appear. In other words, mirror underestimates the closeness of the object. Similar to the mirror, fluoroscopy is not perfect. Depends on the Siam rotation. It can either overestimate or underestimate the depth of the needle. It is currently recommended to use 50 to 55 degrees of obliquity with the contralateral oblique fluoroscopy. It is also important to keep laterality. Here you may see needle tip located far beyond ventral trilaminar line, but the contrast spread is dorsal to epidural space. However, it's important to have three-dimensional vision. And with the epifluoroscopy, you may see that the needle tip bypassed the midline. For this situation, we have two solutions. We recommend to remove the needle and reposition it on the site of the placement when it is important to deliver the medicine to the site of the patient pathology. Or if it doesn't matter, you can use different fluoroscopic modality. We call it ipsilateral oblique fluoroscopy. And with ipsilateral oblique fluoroscopy, you may see the needle tip is still approaching ventral trilaminar line. The spread over here is most probably ligamentum flavum spread. Further needle advancement resulting in robust epidural spread, confirmed with AP position as well. It's better once to see than 100 times to hear. I would suggest to watch this YouTube video. So before I will conclude with this part of the algorithm, I want to present a challenge that one of my friends forwarded to me. He was performing cervical epidural when he got spread like this. He advanced the needle and got this strange spread over here, over here. He checked AP position and he saw this unusual pacification here. He advanced a little bit more and get what looks like patch epidural spread. However, my friend, being well-trained fellow, knew that if you don't recognize the spread, you need to remove the needle and either reposition or abort. And that's exactly what he did. He removed the needle and aborted the procedure. However, as most of you already know, this spread over here is spread of Okada spread, space of Okada spread. And what is the space of Okada? It is the space that's located next to ligamentum flavum. And you guys don't see it because you use loss of resistance. I use contrast and I frequently encounter it. Usually I see the spread on the site of the placement. Occasionally at both sides and very randomly, like on this example, it's contralateral oblique facet. So now whenever you see space of Okada, it's not a complication. It's rather an accepted flow pattern, and you need to continue advancing needle till you get epidural spread. This is the most important part of the algorithm. This is where life and death decisions are made. We divided a spread beyond ventral intralaminar line as either extradural or intradural. By extradural, we mean the spread between dura and the ligamentum flavum. We further divided the spread to either confirmed epidural spread or insufficient or unrecognized epidural spread. By insufficient spread, we mean the spread when the amount of contrast spread doesn't correspond to the amount of medication injected. Usually happens when there is a combined epidural and vascular uptake, like on this picture. So now you have any doubt, explore it. Use different fluoroscopic views. Use live fluoroscopy or digital subtraction. In our practice, we attach a small attachment, small connector, and we explore the images on the screen under low dose or pulse fluoroscopy. In the previous reduction of this algorithm, I called this spread abnormal. Why is it abnormal? It's intradural. So intradural spread can be either subdural, intravascular in arachnoid matter, subarachnoid into the spinal fluid, and even intracaudal. It is important to know distinction between epidural and subdural spread. Epidural space at the cervical spine is narrow, and small amount of contrast may spread at several levels, thus mimicking subdural spread. However, here are some distinctions. With the epidural spread is intermittent, like on this picture. With subdural, it is continuous. Also, with epidural spread, nerve roots are outlined, like here. With subdural, they're not. I want to present another challenge. My other friend was performing a cervical epidural injection when he placed needle here, and then advanced it here, and then a little bit more when the patient screamed. My other friend is a very experienced anesthesiologist, removed the needle, aborted the procedure, took patient to the recovery room, called 911, brought patient to the hospital. Patient was diagnosed with spinal cord damage. So what exactly happened here? My friend misinterpreted this line for that line. If you're paying attention, this is a superior articular pillars. And this line over here is superior articular pillars line. It's different from ventral intralaminar line. Here's the example. Black dots outlined laminas and white dots outlined superior articular pillars. Needle tip is approaching ventral intralaminar line. With further advancement, there is an epidural spread. You may see that epidural spread is locating ventral to ventral intralaminar line, but dorsal to superior articular pillars line. So placement of the needle here can be dangerous. It can cause catastrophic complications. It's important to know distinction between those two lines. This is a pivotal part of my presentation today. This is why you're here. This is why you're listening to me. With the contrast spread technique, I always be able to recognize that my needle is somewhere here because I'm paying attention on the image on the screen. With loss of resistance, there is always a chance that my needle will end up here and even here because my goal is to get loss of resistance. So we describe all our findings and I wrote this article that is free online. Contrast spread technique is better. It is better, I'm telling you. But how can I prove it is? So I decided to do a study where I compare both techniques. And I thought, what do I need to prove? I need to prove that contrast spread recognizes epidural space sooner. That this technique is a more reliable technique, and it is a safer technique. However, more and more I thought about this, more and more I was coming to the conclusion that this is impossible. I cannot prove that contrast spread technique is better. However, I can prove that loss of resistance is worse. So before conducting the study, I looked for literature and found Hoffman study where he compared loss of resistance and the hanging drop technique. I found Leo study where he came to the conclusion that fluoroscopy is necessary for epidural space confirmation, and Stoyanovich study that shows that the loss of resistance is highly unreliable at the cervical spine. So I didn't know how I will conduct my study, and I was thinking about which way to do it. First, I thought that I will do something like Hoffman did. Let's say I will measure skin to epidural space distance with one technique, and somehow prove that with contrast spread technique I can reach epidural space sooner. But those measurements are cumbersome and timely, and it's unfair to the nervous patient laying on the table. So I gave up this idea. Then I decided I'll do crossover study. Let's say a patient comes to me, I'll do cercoepidural with one technique, and few weeks later, I will perform it with the other technique and somehow compare both techniques. But it's impossible to keep identical conditions, needle trajectory, needle placement. So I give up this idea. And finally, I decided I will do a method comparison study. And in my study, I recognize this epidural space with the contrast spread technique first. And this is principle. It cannot be done the other way. Let's say I cannot recognize epidural space loss of resistance and check contrast spread technique, simply because loss of resistance is frequently unreliable. And second, whenever my needle, when it's true positive, whenever the needle inside the epidural space, contrast spread technique always will be positive. So it does make sense. And the second condition was to compare a large needle with a small one. We all know that the thicker the needle, more reliable is loss of resistance. But where is the proof? Beauty and the Beast, yeah? So the null hypothesis was that both techniques are equal. And the alternative hypothesis, no, they're not. The other null hypothesis was that both needles are equally efficient with loss of resistance technique. And alternative hypothesis, no, they are not. So let's say I'm an expert in loss of resistance. As an anesthesia resident and then anesthesia attending, I performed hundreds of epidural injections with loss of resistance. However, at the end of the day, I'll be accused that I'm biased because I'm comparing my technique with traditional technique. So I was looking for some kind of way of objective epidural space identification. And I came over this device that's called epidram. It's a plastic balloon that's inflated when the needle is locating in ligamentum flavum, but as soon as it bypassing ligamentum flavum and gets into epidural space, it deflates. And I had chosen this device not only because it's from United Kingdom, but also because there were multiple studies that show that it's efficient, that the results obtained with this device is comparable with the results obtained by experienced anesthesiologist performing epidural injections with a traditional loss of resistance syringe. I got the IRB approval for the study. And this is how it was conducted. Total 40 patients were divided equally into groups, 20 in each. On all patients, I carefully reviewed the MRI and correlate them with clinical findings. Let's say patient has been in distribution of C5-6 on the left side, and the MRI findings showed some C5-6 disc herniation. I will try to approach C5-6 space on the left. I use local anesthesia for 18 gauge, but not for 25 gauge needle for unknown reason. It's much more painful. Sorry. As I mentioned before, epidural space was recognized with the contrast spread technique first. Then I attached epidram at the needle hub, inflated, and waited for 30 seconds. If the balloon deflated, the results were considered positive. If it stayed inflated, it was considered negative. Then I analyzed the obtained results. You may see that there is no much difference in age between groups. However, there was a big difference in gender and level of placement. And I prefer the smaller needle for females, not only because I feel more for them, obviously smaller needle, less pain, but also because, believe it or not, a female neck is smaller and spaces are narrower. So using a small needle is advantageous. Also, I use a bigger needle at the lower level because the current recommendation is not to place needle above C6, C7, because epidural space becomes progressively more narrow above it. However, the smaller needle gave me some advantage because it's a smaller bevel, plus I use a more precise technique. So I place it at C5-6 with 25 gauge needle. And these are the results. The balloon deflated in 12 out of 20 patients in the 18 gauge group, but only in 2 out of 20 in 25. That's 60% versus 10. And this difference in techniques is statistically significant. And difference in success rate obtained with the loss of resistance with different needles is also statistically significant. So we all know that the larger needle more reliable is loss of resistance. However, what is the reason? And one of the explanation is that resistance is inversely related to fourth power of the radius. Let's say a needle is twice smaller, the radius will be 16 times, the resistance is going to be 16 times higher. Contrast spreading may differentiate epidural space sooner than loss of resistance. My explanation is that for loss of resistance to become apparent, the practitioner has to insert the bevel at the certain depth. Let's say it's 1/3 of the bevel length, or half of it, or the whole bevel length. It depends on needle size, on bevel configuration, and experience of the practitioner. But anyway, it's more than needed for contrast spread to become apparent. Imagine the situation when the media that you have inside the loss of resistance syringe, doesn't matter if it's air or if it's saline, is radiopaque. So you may simultaneously feel resistance and simultaneously assess the media spread on the monitor. So whenever the needle tip bypassing ligamentum flavum and entering the epidural space, you may see the spread of the media and feel loss of resistance simultaneously. It's also possible that you will see the spread of the media, but don't feel loss of resistance yet because you need to advance it a little bit more to feel it. However, I don't imagine any situation when you feel loss of resistance, but don't see any contrast spread, unless you're going to find one. Contrast spread technique is preferred with smaller needles. It's by the nature of this technique. So it is advantageous because you may place this needle at the site of the patient pathology. The current recommendation is to insert a larger needle on the safe level, let's say T1, T2, or T7, T1, and then the thread cutter towards desired level. However, not only it's cumbersome and sometimes impossible to do it, but also it's dangerous because it increases risk for complications like bleeding or nerve damage. This is the comparison of different needle sizes. It's 18 gauge to 20 gauge to a 25 gauge, and this is the needle I currently use for my epidural injections. It's a short bevel needle. This is the length of the bevels. It could be situations that when I still going to prefer loss of resistance. For example, when fluoroscopy is not available or not advisable, like in labor and delivery, when for some reason I cannot use contrast. In those cases, we use gadolinium, but if I cannot use gadolinium, I will use fluoroscopy for needle placement and loss of resistance for epidural space identification. Or when a large bore needle is used, like in the case of spinal cord stimulator placement. So contrast spread technique recognizes epidural space sooner for the reasons I described before. It is a safer technique because instead of relying on loss of resistance, I explore the resulting image and I can timely recognize that my needle is locating deep. It is more reliable technique. And by reliability, I mean not only it identifies epidural space more reliably, but also unlike loss of resistance that frequently equivocal and confusing with the placement, it gives you a definitive yes and no answer. It is a more objective technique because with this technique, I can set the image, I can transmit it on the computer and mail it to any one of you guys, and you will explore this image and you will tell me where the needle is, knowing other conditions. With the loss of resistance, it's impossible. It provides better quality. And by quality, I don't only mean the results or satisfaction with the procedure, but also better control. Every single moment, I know where my needle is. It's easier to teach. I can teach this technique to a medical student in an hour. However, for a practitioner to get to the level of an expert takes years of hard work and many painful mistakes. It is less stressful because it's better control. And when it's less stressful for the provider, it's less stressful for the patient as well. Less risk for hematoma simply, and for postdural puncture headache simply because it's a smaller needle. And yeah, it's less pain with a small needle. And last but not least, it is cheaper. Seeing or feeling, it's up to you. This is a mecca for rock climbers from East Coast. It's located 2 hours from New York, called Gunks. And this particular wall is called Golden Wall. I just completed a very difficult climb. My thanks to Spiros Poulakas, who designed this presentation. And please feel free to send me questions. Thank you.